This is the first of 3 video lectures about pediatric fluid and electrolytes. Here is a table that came from your textbook that provides the pathophysiology of dehydration. So for whatever reason, there's a sudden decrease in the extracellular fluid volume. This results in an imbalance of the electrolytes, primarily your sodium and your potassium. This imbalance alters the intracellular fluid contents. As a result of this, the cells are not functioning correctly, and this can lead to hypovolemic shock if allowed to proceed. And hypovolemic shock can lead to death. When we look at types of fluids, there are 2: sensible, which is what you can measure, and insensible, which is occurring but we can't quantify. Your sensible fluid is in the form of urine, emesis, and stool. But our insensible fluids include humidification with respirations, as well as the transcutaneous evaporative water loss, and we abbreviate that TEWL. And the degree of this depends on the body surface area. Remember that body surface area per kilogram is much greater in an infant when compared to that of an adult, because infants are about 75% water. We worry about the transcutaneous evaporation when a child is febrile. So why are kids more prone to fluid and electrolyte imbalance? Well, as I just said, their composition of water is much greater than that of an adult. They also have a higher metabolic rate. The younger the child, the greater the metabolic rate. Their body surface area is greater, and their kidneys aren't matured to the level of that of an adult until at least 1 year of age. So they can't conserve fluids when they have dehydration. At the same time, this inability to conserve fluid can increase their vulnerability to fluid overload when we treat these children. The other thing we have to keep in mind is that young children are reliant on other people to provide them with fluids. So if people aren't paying attention to the number of stools or the number of emesis versus what they've had to eat and drink, then these children become dehydrated. Also, keep in mind that when a child is sick, they don't want to eat and drink. And so we have to be very creative in how we get them to take in fluids. So by far the most common cause of fluid volume loss in children is related to GI in the form of vomiting and diarrhea. They also lose fluid in their skin when they have any type of a febrile illness. Also, when exposed to the heat outside, if they have burns, or if they have edema that results in a lot of fluid shifting. Respiratory causes, if the child is tachypnic for any reason. And so we would really watch the hydration status of a child who has a chronic respiratory illness or a cardiac problem that causes them to be tachypnic. As the child is teething, they have a lot of drooling, and this is fluid. And then, of course, when we suction people, we are also taking out fluid. And this can be GI suction as well as the respiratory suction. So as mentioned earlier, edema due to the shift in the third space can lead to an intravascular volume loss. And then when we do surgery, when there's trauma and these type of issues, there can be fluid volume loss from blood. So key factors in diagnosing dehydration include obtaining the history of how acute or chronic is this fluid loss. We have lab indicators, in particular the electrolytes, as well as the BUN and creatinine. And it's not just the values, but we also look at the ratio of the BUN to creatinine. Normal is supposed to be 10-to-1 ratio. 15-to-1 ratio can be tolerated, but once we get a 20-to-1, this child is definitely behind the 8 ball in terms of fluids. And then the other factor that we keep in mind is the weight. And so we may not have a weight from yesterday or the week before, but we want to get a ballpark. Mom, how was this kid the last time they went in for a well child check? Were they meeting their milestones in terms of height and weight? Were they on the growth curve? And when they're sick and they've fallen off, you have a very sick child. This ends part 1 of fluid and electrolytes.